incredible.
They're so impressive.
Yeah, so I hope you guys enjoyed lunch, and we are Middle Eastern time, so we are taking it very easy. It's okay to run a little bit late. Maybe you had some housekeeping messages.
Okay, maybe for those people who want to have a little bit longer time to change, maybe go. So we would like all of you please to perform a today's survey before you leave. So use your app, and also for those who didn't download the app yet, please do it now, because after the next lecture we will have the first voting session that we want to discuss with you interactively, so it's very important. And then, probably the most important part of the day, despite all the science and excellence and beauty, we want you to be ready at 7:15 to depart for the gala dinner.
And so the buses are going to pick us up at 7, and they are going to take us to a secret location.
I just say, gold as a miracle.
Yeah, and that's not just the dress code. All right.
All right.
Shall we start our afternoon session?
Yes, because you just got a half. We've got it all.
And so this afternoon, we're going to start with a very famous dermatologist from Dubai, one of the most famous ones from the Middle East, Dr. Amina Al-Amiri. And thank you. Yes, let's give her a great hand of applause. And she's going to share with us how she approaches young patients in her office. Welcome.
Welcome, please.
Everyone. Good afternoon, and I hope you enjoyed your lunch. Today I will talk about young patients in my practice, and I'm really glad that I have been asked to give a talk about this interesting yet not well-studied topic. It gave me perspective on how to look or how to manage millennial and post-millennial generations or Generation Z. This is my disclosure. In my presentation, I will go through this content. So they tell us that economy is bad, yet aesthetic medicine is rapidly growing. It's expected to grow to $73.6 billion worldwide in 2022. So we think too much about aesthetics. We are beauty focused. We even judge each other on how beautiful we are and how attractive we are. And for this reason, more and more aesthetic clinics are opening. It's becoming widely accessible, and aesthetic treatments are being done by professionals and unprofessionals people. And sadly, aesthetic treatment is becoming uncontrollable and very much affordable. Now, if we look into the reason of this rapid growth in a time of bad economy, I think social media has a major factor. We all use our social media, and 600 million users daily, they use Instagram, and 187 million people per day, they look into their Snapchat. And young generations spend hours every day to look into their social media. They see the celebrities and influencers, how they are transforming, how they are becoming more beautiful, and they will be wanting to look like people that they have never met. They want to have, it's putting pressure on them to look more beautiful and to have more flawless skin. So they are there seeking for aesthetic treatment. And we can say that treating young generation it's difficult to justify, yet it cannot be ignored either. As I said, they are looking for aesthetic treatment, so we have to be there too, and to provide them proper aesthetic treatment. And to show you how young generation to which extent they can go to follow the fashion, you can see, You can see the new trend of applying glue in their upper lip and lower lip to elevate their lips and to look more like a Kardashian lips. So they really harm themselves. So how to justify prevention and early treatment? I think one of the major justifications is that we know that facial aging starts very early in age. We also know the effect of pollution, stress, unhealthy lifestyle, sun exposure. We know this all accelerates aging. And we have simple, relatively safe treatments and procedures that we can do in our clinics to delay the aging. So why not? Why not start early treatment and have our patients look their best in their 60s and 70s? This is an article that 14 specialists in aesthetic medicine from across the globe, they gathered in a meeting and they came up with prevention and early treatment protocols in the patients who have no signs of aging or minimal signs of aging. Tatiana was one of them, one of the group. Maybe Tatiana later can give us more elaboration of that. In this second article, what they did is they studied age-related physiological changes, and they gave us a protocol and for treatment and prevention according or based on this age differences or physiological changes. So to sum it up, yes, we do recommend and we can justify prevention and early treatment in young age group to delay aging, but we have to be careful from the negative part of it. The financial effect is very clear to everyone, but by now I think a lot of you heard about Snapchat dysmorphia. Snapchat dysmorphia was discussed or first mentioned in 2018. It's type of body dysmorphic disorder. And what basically means is the patient will come to you asking to look like their filtered image of themselves. And according to an Anxiety and Depression Association of America, BDD is affecting 1 to 50 people or 5 to 7.5 million people in the USA. That's a huge number. And that number will increase with the increase of aesthetic medicine. This disorder is also a hidden disorder. It can stay for 10 years without being diagnosed. But maybe it's hidden because we are not aware of it and we don't know how to diagnose it. It's really serious to understand the disease and to diagnose this disease, especially that 80% of BDD patients report suicidal thoughts, and 1/4 of them actually commit suicide. So you have to be aware of this disorder, and you have to be aware of how to diagnose this disorder. And according to the American Psychiatric and Statistic Manual of Mental Disorders, BDD is diagnosed based on 4 criteria. The first criteria is that the patient should have preoccupation of non-existing or slight defect in their physical appearance, and that preoccupation should be at least 1 hour per day. The second criteria is that they should have a repetitive compulsive behavior which is related to that defect in their physical appearance, which I will talk about it in a second. The third criteria is that the preoccupation and repetitive behavior should have significant or clinical significant impact or negative impact on their social life and on their occupation or study. The fourth criteria, that it should be differentiated from eating disorder, although some of the BDD patients also have eating disorder. This is some of the compulsive behaviors that can accompany or be present with BDD patients. Conformity. This is a really major issue in our country, and I think worldwide. Young age group do not feel comfortable going out from their house without applying makeup. As young as 15 and 16 years old, they still don't feel secure and comfortable facing others without full makeup. Being day or night, they are always with full makeup. The other compulsive behaviors can be, of course, they compare themselves to others, frequent looking into the mirror, excessive shopping, excessive exercise, and the rest. just to show you what the filter does. You can see the patient before filter and after filter. She really looks amazing with filter. Her skin tone is great, her face is slimmer, lifted up, her eyes are bigger, lips bigger, nose is slimmer. Who doesn't want to look like their filter image? It's really great. And I also put my picture. It looks like a passport image, but it's okay. So this is without filter, and this is with filter, obviously. I look great. My rosacea doesn't show. My pores is good. There is no pores anymore, no wrinkles. So it's really great. The filter does a great job, but it's not realistic. But if I will spend every day hours looking at my filter picture or a celebrity filter picture, and then I will look into my own picture in the mirror, the reality, if I will face that reality, maybe also I will get depressed. So imagine that pressure that it is on young generation, and they spend hours on social media. Now, young generation social media for them is life. So this is what the filter does. It changes your skin tone, softens or removes lines and wrinkles according to the filter. It also changes your face, size of the nose, the eyes, lips, etc. According to the American Academy of Facial, Plastic and Reconstructive Surgery, 55% of plastic surgeons have been requested to do cosmetic procedures for a better look on social media. So we are going out of control. They want to look like their filtered image in the social media, and they want to look better in the social media. So they're focused on social media. They're having social media addiction. Their life is like doesn't belong to them anymore. It's all about social media. They even plan to go out just for the social media. It's crazy. They go and eat for social media. So just remember, if you are in your practice and you diagnose or you face a patient that has a criteria, that she fits the criteria for BDD, please do not start any treatment. Understand that it's not us that they need. It's not you whom they need. They need to have a proper psychological assessment. So refer them and do not start the treatment. And if you started the treatment, not only they will not be satisfied, and they will have addiction on the treatment, so they're always not satisfied. They want to do more and more. They end up having addiction to aesthetic treatment. Also, if you acknowledge that there is a problem and you started the treatment, you also worsen their condition. So please do not start any treatment, because at the end, if you started and they're not satisfied, they will ruin your reputation. There's some references about Snapchat dysmorphia. Now, in my practice, like all of you, I started to have more and more young generations in my office. And you can see this is 2016, and here, this is from the beginning of August, and you can see how it's increasing. Of course, this will go higher. Not only they come for skin problems and laser hair removal, they come for aesthetic treatment. They come specifically for injectables. So what I do when I see my patient, before entering and seeing my patient, my assistant usually briefs me with some history. Then I enter, I chat with my patient, I try to make her comfortable, and when she's comfortable, she opens up and tells me everything. As Tatiana does, I usually give at least 30 minutes for my patient, especially if they are there for injectables, then I take it more serious. If the patient is visiting for a skin problem, then it's easier and it's more straightforward. But if she's there for injectables, then of course I sense her psychological maturity or background. They usually come with their filtered image or a celebrity filtered image. So I try to explain that this is not realistic. We cannot give her the look of her filtered image. So I bring them back to reality and explain what she needs after doing proper assessment. And to do the proper assessment, of course, I give her the mirror, a big mirror, not a small mirror, and she looks at herself, and we look together how to improve her skin quality, or if we will do injectables or whatever, so do proper assessment, and then we put the plan together, and of course we document it with photography. If the patient is less than 21 years old, then I always ask for the mother to be present. So, if the patient doesn't need injectables, then I don't inject. He doesn't need it, or she has a psychological problem, I don't start. And you also have the right to say no. If you think that she doesn't need injectables, please say no. And if you think that she needs the injectable, then be very careful. They are very sensitive and very vulnerable. So be careful, understand your ethics, and avoid bad practice. Follow any guidelines you know, and check the law in your country. I checked with my lawyer, and my lawyer said in UAE, any patient who's 21 years below, by law, you need to have a written consent form to perform any procedure, being simple procedure or major surgery. So you have to remember this. Again, the steps that I take, if the patient is for skin problem, then easy. If the patient is there for aesthetic problem, or she wants to do some injectables, then I try, and she has a skin problem, then I try to direct her to treat the skin problem first. A lot of times, of course, I combine prevention with treatment, and I will talk about injectables. Now, in prevention, as everyone, I advise for a better lifestyle, healthy diet, water, drinking enough water. Our girls tend to not drink enough water if they are going out because they don't like to use public bathrooms. Exercise, they are becoming better with exercise. Sun exposure is an issue. Makeup, as I said, is a big issue. It's not realistic to tell them stop applying makeup, but at least we can educate them on what's the proper makeup for their skin type. The skincare routine, again, as you all know, but we have to be careful when we are prescribing sun protection cream or moisturizer, that we should help them to choose the proper one for their skin type. Topical antioxidants and anti-aging, I like using vitamin C for almost everyone. If the patient is below 29, I tend to give them 10%, and if they are older, 15 or 20%. Of course, you can give 20 or 15 if they are younger. Vitamin A, alpha hydroxy acid, growth factors, peptides, it depends on the skin condition. So I assess the skin, and then I give the topicals accordingly. In the clinic, if the patient doesn't have anything, then maybe I plan for a regular facials or simple mesotherapy. But if the patient has any problem, like acne scar or something, I like to do microneedling. And as everyone said, I also like to do combination treatment. Combination is always better outcome and better results. So those are the treatments that I can use in young generation. I personally don't like or don't feel comfortable using body contouring measures, energy-based devices for stored collagen stimulation, or threads in young age group. Injectables, as I said, I assess the patient, see if she has any congenital deformity, if she has any noticeable asymmetry, that she really needs injection, or she's doing it for fashion, or she has a psychological immaturity. Remember again, acknowledging to do the treatment, it means acknowledging that there is a problem. We all know that toxins are FDA approved from 18 years old, and please understand physiology and anatomy in young age group before starting any injectables. When I do injectables, I personally don't like to follow the proportion and facial analysis 100% in every single person. It's a guide that I use, but I like to keep the identity, and I like to keep it natural. So I always aim for individuality, and I don't aim for perfection. And just to show you, this is one of the Kardashian sisters. Now we can argue where she's more beautiful, before doing aesthetic treatment or after. Maybe she is beautiful in both ages. But to me, not only she looks more masculine here, but she lost her features.
Yes.
This is Bella Hadid, or Gigi Hadid, one of them. Again, after aesthetic treatment, she is still beautiful. But again, she lost her features. And to me, she doesn't look like herself, although she is still beautiful. Some of the pictures before and after in my practice. This is a patient who has acne with PIF. So I did one session of peel, and after 1 month, he looks better. This is a patient who's 17 years old, and she had acne scars. So I did PRP with derma roller, and you can see the difference after 3 sessions. Another patient with acne scar, 4 sessions of PRP with dermapen, and you can compare before treatment and after 4 sessions. This is a patient that we did a trial of PRP for underarms pigmentation. Actually, the patient insisted on doing PRP, although I told her this is not indicated for pigmentation, but she wanted to do it. So we did it, and I gave her mild bleaching cream, and she disappeared for 3-4 months, and I thought she didn't get better. But surprisingly, she came back, and she said after 3rd week, I was already better, and I stopped everything, and she still looked better. Young age group like to do injectables everywhere, but the majority of them, they like, in my practice, they like to do their lips. Now, I use soft, balance, intense, volume, I use everything. It depends on the case. To contour, I usually use soft, and to give some hydration, I use soft. For a little bit of volume, I use balance, and of course, I combine. I also combine cannula and needle. Sometimes I do only cannula, sometimes I do only needle, and sometimes I combine both of them. So in this case, I did Bolletero Balance 0.8 with cannula. This is another case that I also did balance. This is again balance, but I give a little bit more amount, 1 ml. This is a patient that I did intense with cannula. Another case, intense with needle. And this is a case that I did volume with cannula. Nose is another area that young age groups like to do. And I always use intense for the nose, and in the 90% of cases, I use cannula. I use sometimes needle, but I prefer cannula over the needle. Another patient, she has a little bit of hump here, so we straightened her nose to remove the hump. And in this patient, I did very little on her nose, but I did also her tear trough. This is another tear trough. And in this patient, I did her cheeks, and I also did her lips. You can see that still she looks herself. She didn't lose her features. This is a patient that we did her chin. She didn't want any toxins to be injected, so I used intense. I use intense in the chin and jaw, and I also use radius according to the case. This is a patient that had elongation of her face, and I used radius, half a syringe on each side, on her jawline. And this is a patient that hollow on her buccal area, and I did 1 ml of volume on each side with cannula. Last patient, she had heaviness in her lower face and more of deflation in the mid-face. Maybe it's more clear on this side. You can see the deflation here, and this is after treatment. So what I did is I injected her volume and intense with cannula and needle to make her face more shortened and mid-face not to look so much deflated. I also did her tear trough. So in conclusion, aging starts early in age, which justifies starting early prevention and intervention treatment. Of course, we need more studies for that. Social media has a huge impact on young generation, which makes them vulnerable and sensitive at risk for bad practice. We all need to be aware of the existence of Snapchat dysmorphia or body dysmorphic disorder. Practitioners must understand, we need to understand our ethics and obligations toward young age group. We need to guide them and put a proper plan that suits them. We individualize, as Tatiana said. Try to avoid over-treatment in young age group and in any age group. And again, I advise you to follow any guidelines you know, and please check the law in your country. Thank you.
Thank you very much, Debbie. Beautiful. And yes, they are special, the young people.
Yes.
A lot. And sometimes when I listen to lectures like yours and when I'm researching, I just hope that my 6-year-old son will not get like that.
I know.
But you never know.
You mentioned a lot of insights for young patients in the Middle East, but actually I think it's the same in Europe.
It's all over the world.
It's
the
all
same,
over the
actually.
world. It's not only here. They are becoming like it's really becoming uncontrollable. They are always on their social media and looking at their filtered image or celebrities' filtered image. They think that this is reality. By looking repeatedly, you think that this is reality. And then they compare themselves to others.
It's a fake world. And what I really sometimes think, when I see, they live on a social media. So why they really need the normal one? They live in a virtual world.
Exactly.
So I think soon they will not going out of their homes, not to school, whatever. They will live just in the social media. Probably they do even now.
They go out for the social.
Yeah. And
They have plans for the social. They eat, and not on the table when they have the dinner. No one will touch the dinner. The pictures have been taken and posted, and then they will touch the dinner.
Thank you very much.
Yeah, thank you very
That's
much.
great.
Thank you. Beautiful lecture. And
We have a voting now.
we have a voting now.
All right, so everybody
please
take
your
your phone
phones.
out of your pocket. And now it's okay to take your phone, of course, not for taking the pictures of the patient, but actually to answer some
This is the wrong
questions.
screen. We need the first
Yes.
voting about the young patients. Oh yeah, here we have it. So, in your practice, what is the share of patients below 25 years? Less than 10%, 10 to 30%, 30 to 40, 40 to 50, 50 to 70, more than 70%.
So in your app, go to the menu and then go to voting. And then you can have choices 1, 2, 3, 4, 5, or 6. So to answer your questions, what is your share of patients under 25? How many seconds are left? 11 seconds.
11.
Okay, guys, quickly.
Quickly. This is the first question. You have a little bit more time. For the second and the third, we'll give it a short time. Okay.
All right. Yeah.
So it's what was again?
Now, how many patients? What is the percentage of patients under 25
10 to
years
30%.
10 to 30%. That is quite significant, actually. Between 10 to 30. So it's between every third to every 10th patient is under 25. That's actually becoming a
But when you
very,
look, I mean, this was actually how many percent there are. 10 to 30%, it's 40%. 30 to 40% is 29. So when you look between 10 and a half, so about a half, up to 50%, we have 40 plus 28 plus 12, so it's about 80%. Hola, it's a lot.
well,
And this is just below 25.
there are actually some.
Do you have old patients, actually, by the way?
There are actually some doctors here who have at least half of their population is below 25 years old. Do you think this is real? Or maybe there's pediatricians. Are there pediatricians here in the room?
Do we have pediatricians in the room? No. I mean, but that shows what, I mean, that's just shown us that young patients really start very, very early. And then usually, about 6-7 years ago, I would say, oh, this is normal in Korea. But now it's becoming normal all over the world. Or maybe in Brazil, but they rather do more body contouring. Am I right, Gabriela? With the 18. But it's a lot. So we have to really focus more the education and also the psychological impact, or the 6D, what I was talking about this young population.
And I guess, as treating physicians, I know that we have this thing that we don't like social media, but this actually proves that we have to get on this train if we want to reach our young patients. So maybe it's not nice to start, but once you get into it, it's quite okay to post something now.
Yeah, and it actually contributes to their education.
Absolutely.
And that's a good thing. So let's go to the second question, because I think we have 3 questions.
The second question.
Okay. What is the average age of your young patients? Number 1, younger than 17
For the
2,
pediatricians.
17 to 20, 3, 20 to 25, 4, 25 to 27, and 5, older than 27 years. Oh my gosh, Annie, we are so far beyond all of that.
I know. It's like, well, we are older than 27. We are 27 with a few years of experience.
What doesn't kill you makes you harder.
3,
3, 2, 1, and...
action. Let's see what we have.
Okay, to be honest, I'm happy to see the first
Yeah, me too.
answer.
Me too.
Because I think at least until people are 18, we should, except in some genetic...
Well, I learned that here in the Middle East, it's, at least the toxins are not allowed under 18, but the fillers are, apparently. In Europe, I think also the fillers are not allowed under 18, right?
Actually, it says any kind of aesthetic treatments, because they are not able to do their business. So let's see what's the highest number, if I can read it. It's 36, is that right? 20 to 25 years. And then about 1/3, 30%, 25 to 27. So actually, most of them are above 20.
Yeah. Quite an even distribution. So I would say 20 to 27 in an even distribution.
Yeah, the median is probably
makes
25,
sense.
something like that.
Yeah, exactly.
Okay, so
Great.
25.
So interesting. So let's move on to the next one.
Yep.
So the question is,
From your experience, what is the typical concern, request of young patients? 1, I want to look exactly like this celebrity on this photo. 2nd, I want lips like Kim Kardashian
or Jenny,
or Kylie Jenner.
Kylie Jenner.
Number 3, I want to get rid of the dark circles below my eyes. 4, I want to look stunning for my wedding day. 5, I want my cheeks to look fuller. A wedding day in Europe at the age of 25 would be far too early. So let's start.
All right, here we go. Get voting, guys.
Did you know that Kylie Jenner actually developed the app that simulates her lip gloss, how your lips would look like?
Really?
This is the best way to sell the products, obviously. She's the youngest billionaire in the world. So, and we have our answers. Okay, so the celebrity, not really just the Kim Kardashian, and the dark circles. And the fourth is the wedding, about the same like a Kardashian.
And the cheeks, I'm actually surprised that the cheeks are such a small amount, because all these young women, they love to have their cheeks done. I mean, they have like, this golden ratio point that should be
But you
accentuated.
should think we are here in the Middle East. They have a little bit higher cheekbones,
They do.
like Slavians, like me, than they have in the Middle Europe where we work.
Yeah, that's right.
But of course, genetically, and that's actually really a good, I think, that represents also the genetic background, is the dark eye circles.
Yeah.
And this is something that definitely dark eye circles is due to the genetic predisposition, but it is also something that appears in a very young population. And we all know if you wait very long until the patients get 35 or something like that, they have additional skin laxity or whatever else, and then it's too late actually to treat them maybe just with the fillers. So, dark eye circles, yes, celebrity lips, yes, social media, patient media, 25, and social media is important for them. Thank you very much for your first
Voting session.
and we will continue now with something that is also bothering a lot of young and older patients, and we would like to welcome back Dr. Gabriela Casabona on stage to speak about
Her patients with post-acne scars. Let's hear it for Gabriela.
Back again. So, acne scars, especially atrophic, because there are a lot of types of acne scars, right? So the atrophic specifically type, for me, are one of my frustrations at the beginning of my career, because I was a laser professor for many years in Brazil, so I used to be exposed to all the technologies. And even though I could combine all of them, I couldn't reach really a perfect result by using only energy-based device or even surgery, punch, graft, fat grafting. to get the perfect result for these patients and long-lasting. So I started to look a little bit more around what we have. So how serious and the psychological consequences are for those patients are really impressed me. But they're not only associated with loss of collagen in the thermal area, but also if you have very severe acne condition, you also will have impact on the superficial subcutaneous area, especially on the cheek. So you have to look at that too, and we have to address that. But how? Energy-based devices do not, years ago, were not designed to treat the superficial subcutaneous layer. We had fillers for that, we had fat for that, we had other procedures, but not really energy-based devices. So if we look at this patient has more than one type of acne scar. But if you look really in this area, you will see that this patient has atrophic, meaning dermal collapse plus reabsorption of the superficial fat layer, and also a thinning of the epidermal layer. So how do we address all this with one procedure? Impossible. So look at this, you have really a collapse. So it's not only to treat the dermal thickness. I treated many patients with CO2, non-ablative Fraxel lasers. You can thicken the dermis, but will not correct the depression. How do you correct that? So I started to look into, when I started using dilute radius, I started looking on what was the, the usefulness of radius dilute maybe, and I started using in those patients alone radius dilute to try to create a support. But then I had to do a lot of sessions for that, and those patients, normally they came to me, they had done tons of procedures before. They really wanted something radical. So they always come asking for deep healing, phenol, all those, very radical treatments. I want to be treated in one session, I want to look good. So I said, yeah, if radius dilute alone is not enough, what can I combine with that? And this was the early ages when I was starting to try to combine Ulthera and radius altogether. It is proven already that both of them stimulate neocollagenesis, but can I combine them for atrophic acne scars or not? And which kind of advantage I do have in the combination or not? So we can improve, it's published before that we can use hyaluronic acid to treat those, but it's not long lasting, unfortunately, because if you inject a very superficial hyaluronic acid, it has to be very thin hyaluronic acid. It won't last very long. So what can we do? So I did a retrospective study when I combined calcium hydroxyapatite radius dilute, 1-to-1 dilution, with microfocus ultrasound to try to see if I could get a good result, long-lasting, and one-shot treatment. To understand the mechanism behind it, we have to understand that we are stimulating collagen. It's not very easy to stimulate long-lasting collagen type 1. So we have 3 paths to stimulate collagen. One is the biomechanical effect, which is biostimulators. Second one, injury, healing process. So if we use heat technologies that goes up to 60 degrees, CO2, non-ablative Fraxel laser, Ulthera, all this stimulate healing cascade. If you're stimulating healing cascade, then you're obligating your patient to heal and produce collagen. The third path, which is the most common and older one, is to stimulate collagen through an indirect stimulation, which means any heat around 45-50 degrees is not high enough to coagulate proteins, but it's high enough to stimulate the liberation of heat protein shock, which indirectly stimulate the fibroblasts to produce collagen. If we combine Radius and Ulthera, we are combining the tree path altogether, which makes the findings of some studies published, meaning that the combination brings more collagen than the procedures alone. We understand why. So the objective of my study was to retrospectively evaluate the patients where I used Ulthera and Radius all together, small number of lines of Ulthera just to create collagen, not lifting, and Radius dilute in the same session. So I evaluated the patient through photograph methods evaluation and using the Goodman score scale to score the patient. So 2 transducers were used. I wanted a more superficial collagen stimulation, not a lifting, so I used the 3.0, 1.5, 75 lines per side, and in a crosshatch. You will see a picture of this. So this is how I put the lights normally. The injection, this is how I put the lights. Then after the Ulthera, immediately after, I would put Radius in a subdermal manner in a fanning technique, which we'll see, diluted 1:1 with lidocaine 2%. So subdermal injection with a 25 gauge cannula. Very superficial. But, yeah. So very superficial injection and very small amount. You will see, you cannot see lumps after the procedure. You will see the regular radius edema, but not really lumps. It's very even, the distribution. If you inject 0.1 ml per trace, is very small amount. So I assessed the Goodman acne scars and the patient satisfaction scale after 90 days. This is the Goodman acne scar classification. And this is the subject satisfaction questionnaire. It's already, this table is already published many years ago, so I use that for studies, very good. So assessed in the day 90. So the improvement showed to be statistically significant after 90 days. One shot treatment, Ulthera 150 lines, and 1 syringe of Radius split in both sides, half a syringe solution, so 1.5 solution and solution each side. So subjects were very satisfied or satisfied. Most of the patients were very satisfied. And these are some of the examples. So this is a patient that had atrophic plus ice peak scars. You see that the atrophic scars got much better, the ice peak not so much. Ice peaks are better to treat with lasers. It's a very superficial, dermal, I would say, lack of collagen. So it's better to be treated with other type of treatments altogether. This is another patient. This patient had all kinds of treatment the last, I would say, 8 years. She came to me desperate. So this is the first patient I tried this combination. It was very successful in my opinion. So you can see improvements in 90 days. They were very significant. This is another patient. This is a very interesting case, more recent one towards the publication, where I did the 3D image and I could see the vectoring. I could analyze. So she was complaining, she was an Asian patient complaining about the atrophic acne scars, but mostly she didn't want to change the contour of her face. She was very afraid of that. So I just used exactly the same protocol. She was very happy with the result, And you see what happened when you use? So you create horizontal tightening in the face if you use that kind of combination. But when the patient comes to you with a severe acne scar and just neocollagenesis is not enough, what do? So this is a patient after treating with Ulthera and Radius Dilute. She had a good correction of the acne scar, but if you look at this area, so if you look at the acne scar is better, but then this line right on the side of the nasolabial fold, she was complaining about this. So she had a good result, but it was not perfect. But the thing is, what do? Do you inject hyaluronic acid? She was very afraid of this. So what can I do to stretch this area a little bit more? So I decided actually to use, to stretch the structure, to use the projection of the bone, the lower border of the mandible, and also the zygomatic arch to stretch and see how we got the correction of this lower part just by enhancing the frame. What do you think happened if I have a beautiful painting and a shorter frame? The painting will be all this and I won't be able to admire the beauty of it. But if I put the painting in the right frame and stretch it, I will have the best view of it. The same thing happened with our face. So this is another thing that you can add to your acne scar treatment if the acne is distensible acne scar, to stretch the bone structure. This is the vector adding up. So you add up to the horizontal vector, the projection, and the vertical vectors too. This just shows how much more projected the arrows go if you add something to the bone, which is a good thing. And this is the same case after the protocol of Ulthera and Radius, and then I decided to stretch the structure also, and improved more. And this is after a year and a half of everything. So you can see that it is long-lasting. I can see this patient, I've been seeing her for many, many years, and I do only Ulthera, eventually Radius Dilute every 2 years. There were no reports of severe adverse events. The only thing that were reported was a little bit of edema in the first 2 days and bruising sometimes. So the treatment is effective, is a very cost-effective method. If you think about 10 sessions of CO2 or 1 session of 150 lines of Ulthera and 1 syringe of Radius Dilute. It's not the only treatment available, but I think it is a good combination, cost-effective and effective way of changing our habits. Because if we stay as we are, as long as we live, we kind of stay in the comfort zone. We don't do anything neither better or different. So we kind of die being alive. So just try to do things better along the way. Thank you so much.
Run. Oops. I was surprised, we were too fast. So I really love your results, and especially because you're showing both effects on the acne scars and on the lifting and tightening. Yeah.
So how many of your patients, actually request proactively acne scars treatment with Radius, or do they don't know? Because usually patients, when they have acne scars, they come with lasers, fractional radiofrequency, microneedling, and so on.
Normally, I evaluate the amount of atrophic acne scars, even if they come asking for lasers. I show them the different types of acne scars, and if the amount of acne scars they have, like percentage, if I look like the patient have 80% of atrophic or distensible acne scars, I prefer to start with radius and Ulthera and explain them why. If they have more percentage of ice peaks and also some atrophic acne scars, I would prefer to start with laser.
And most of your results is just after 90 days, let's say 3 months, you see a good result. But did you notice that the results actually keep on improving?
Yeah,
Like
the first
even in
year.
yeah, exactly. Do you mention this to your patient? And also, what do you say about the permanent effect of these treatment modalities together?
That's what I'm saying. I mean, it's not only for the face, for the body also. When we combine Ulthera and radius in the first session, and then we reevaluate the patient in a year, they do not lose the result. So normally, when I put something on top, I do just Ulthera treatment to re-stimulate the collagen because we keep aging, we keep losing everything. So that's why I said that if I have to inject radius again, because the patient needs a little bit more support, it's not in the first year. Normally, it is in the second year or third year, as far as because I've been using this technique for 6 years. So I have been following up patients for more than 2 years. So normally it's very long lasting.
Exactly. And if they want a true permanent result, they just have to come back now and then.
Yeah, it's like for everything. I
Exactly.
mean, there is nothing forever.
No.
Even that's what many
even
patients
surgery
wrongly
forever.
believe. Even with exactly, that's what I tell my patients. Yeah, but that's so much money. I could do a facelift. And I said, come on. First of all, with the facelift, you just rehydrate. Your perioral lines will not go away. Your skin becomes thinner and thinner. If you have a pizza, you can't make it thin as possible. One day it's going to break, and the same happens with our skin. So, thank you very much.
Yeah, thanks, Gabi.
And we have our next live demonstration.
Exactly. I think we're going to go and see if we can get a connection with the injection room.
Dr. Shazia Ali, and treating young patients, how to implement correction, beautification, and prevention protocols.
Exactly. So I'm curious.
Can you hear us?
Can you hear us?
Oh yeah, at least we see you. Can we hear you?
Here we go. Could you tell us something about your
Wait, I
patient?
can't hear. Sound? Can we have a sound? Or is she not?
You
You're wearing a
are
microphone?
live. Yes,
Hello?
you are live.
Can
All right.
we? Can
Can you
you
let
help
them
us with
know?
the sound? Okay.
Okay, well,
Well.
a disclaimer, that's also nice to look
That's
at.
also
I mean,
nice.
it's great. I love looking at disclaimers. But
Yeah, and actually, just because of the disclaimer, I've been asked by 2 or 3 other speakers as well, and also Yanni and I, we want to emphasize that please don't make pictures from the patients. Of course, from some of them, we have permission to use it for the lecturing. However, there is no patient in the world that want to see their photo on the social media except they post it themselves.
well,
So do all of these text things, blah, 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 where the patients can't be recognized, but don't make pictures of the patients that can be recognized.
and then maybe it's now time to go to the, or should I go and tell them? Or can somebody go and tell them that we are going to get live now?
Do we have connection?
Anyway,
Or Alexei, should we rather than go with lectures before we lose more time?
I was just looking at the last slide of Gabriella showing 4 kids on surfboards. In the meantime, I think she has 6, right?
Yeah.
6 kids. Look at that woman. Looks
And
like
as I said, the last was just 4 weeks ago.
4 weeks ago. And she looks
Are we live
like
now?
she's-
Hello? Can you
Hello.
hear me?
Yep.
Yes.
All right, great.
Now we just need to see you as well. Oh yes, now both things work. We can see you and we can hear you.
Perfect. We had a little bit of audio trouble, but now we are all sorted out. So, today I'm going to be injecting a young patient. I'm practicing in Saudi, and more than, I would say, 60% of my clientele is millennials. So we see a lot of young patients. So when we are approaching young people, my approach is in 3 steps. First of all, analyze the face and see where we need to do correction. Even in young faces, sometimes we need to do some sort of corrections. Second thing is beautification, and this is what actually brings them to our clinic. The beautification, they want to do their lips, they want to do their nose or chin. Texas has been very popular, but of course you have to assess and you have to advise, because they are looking at, like we have been talking about, social media and everything, and they actually don't know what they actually need, but they just want something that they see on social media or on TV. And the third thing is prevention. Aging starts as early as 20s. And there are multiple studies which have shown us that actually you start losing collagen right from the after 15, 16 years of age. And by the time you're 25, around 2 to 5 ml of collagen has been lost from your skin, especially in the face and neck area. So prevention is something that we need to start working on, because as we talked about today, the way we are treating aesthetic patients is changing and evolving. And as we are getting more and more experience in this field, we are changing our practices, and we are actually making sure that whatever we learn, we share, we improve our techniques, and we move forward. And a lot of consensus have been published, which makes it amazing. We were always debating, should we touch the young patient or should we not touch the young patient? And now the consensus is, why not? So my 29-year young patient is Jihad, and she's very pretty, as you can see, and she has almost like what you call it, like a baby face. And but to correctly assess her, we have to let her sit up at 90 degrees, because when you're reclining at 45 degrees or you're lying down at a lower angle, your face is actually pushed back and the fat pads are sliding back. So you can't actually see all the problems that you see when you're upright. So first thing we see is, of the top, is the skin. She has combination to oily skin, and combination to oily skin is good in the way that you don't start to get very fine lines and wrinkles, but areas which are dry, you can actually develop fine lines and wrinkles, as we can see around the nasolabial folds. So before I sort of had a chat with her and I said, what are your concerns? And she was saying the usual, the nasolabial folds, they are actually bothering her. Can we have a smile, please? Yeah. See, when you see the smile, relax. See, the wrinkles that come, they actually stay for a few seconds and then they start to sort of go away. Second thing is, under the eye area, we have a little bit of developing of lacrimal grooves. There is a little bit of hallowing and shadowing under the eye. And apart from that, there is asymmetry between right and the left side of her face. If you notice, she's been sleeping mostly on the left side of her face. And if you see here, pads of fat are a little bit deflated compared to the other side. So this would be actually coming under correction if we are trying to bring the symmetry back to the face. So here, if you notice, we have less volume in the mid cheek, and even the nasolabial fold is a little bit more deeper, and even the hollowing under the eye is more deeper. On this side, she has a little bit of fat herniation, so you have to be very careful when you're trying to sort of augment on the under eye area, because too much product pushed under the fat pad is going to make it herniate more, and instead of making the area look better, it's going to look worse. So you have to go very small amounts under the fat pad, which is herniating and protruding, and just make sure that you massage it downwards, not upwards, so that the fat is not, herniation does not get worse. On this side, actually, we don't have that problem. So what we are going to do for her is we are going to go and add on a little bit of a volume in the deep medial pad of fat, and in the little bit of medial souf, and a little bit in the lateral souf. We are going to support her nasolabial pad of fat by injecting a little bit in the piriform fossa, and then we're going to do a little bit of very one-to-one diluted radius to add volume to this area. I'm going to do more of this area compared to the other area, so we can have a little bit of a symmetry. We can even add volume, but I feel that adding volume is something that I don't like to do. As time passes, it starts to sag, and I don't like this volume. So if you can use some energy-based device like high-intensity focused ultrasound, it would really help to sculpt this fat and give us a better shape. Looking at her face at 90 degrees, see here, she has a little bit of a hump on the nose. This can come under beautification. We can work on that, but that would not be my first target. My first target would be to give her something that makes her look good, feel, and look really instantly good, and a change that she would appreciate. And these are the things I can mark, and I call it my cosmetic roadmap. And if I put down this map on my first consult, then I don't have to every time think about what am I going to do. I have the things ready, and she comes at different frequencies, 1, 2, 3, 4 months apart, and she keeps on sort of ticking the checklist if she feels that her first treatment was worth it.
I don't mean to rush you, but you have under 15 minutes
So
left.
yeah, so basically, so I'm pretty much done. This is what I'm going to do right now. There's a little bit of asymmetry in the eyebrows also. So a little bit of hyperdiluted radius in this area to lift up this eye would also help us in making her look more symmetrical. So we're going to have her rested. I'm going to use, So I'm going to use a little bit of Lido with epinephrine to just set up my first point of injection. I don't like to make too many openings because as we have been reading about biofilms, they are very real, and the more openings you have, the more chances of after injection, if she touches her face, contamination and bacteria can actually move in, and later they can cause acute infection, or they can even cause a little bit of, I'm going to put a little bit in the cribriform also, so that's it done. And one more here so I can work on diluted radius. Alright. So we're going to start with the Bolotero balance. And I'm going to use 25 G cannula with that. All right. So, give me a piece of gauze, please. All right. So what I'm going to do is I'm going to go perpendicularly. I've heard my first click, then my second click, and then I'm under the muscles deep, and I'm right here, right now, on the bone. I'm going to inject 0.01 here. And you have to be careful as in this area because the tissues are very thin. We have very thin muscle and a little bit of very thin skin, and there's no distinct pad of fat to hide. If too much product is put, it can become very visual. We're going to inject a little bit here. I'm going to go in the deep medial pad of fat, and we're going to inject.
I think it's not such a big question of what product you use of the Bolotero range in this area, as long as you respect the layer and the amount. You know, if you inject 0.25 ml of Bolotero balance, in comparison to inject just 0.05 of Bolotero volume, for example, probably it will have a comparable result, and with both you will not have a side effect. So sometimes I even prefer, especially in the younger patients with the thicker skin, considering the distance between the lower eyelid, the skin, and the bone. So these patients with very deep set bone of the infraorbital margin, to use rather a product that has a little bit more projection, but to inject significantly less, because it will rather stay
because of the higher viscosity in the exact point where I have injected it, than to use, for example, balance. But this is just a comment, so that is, there are many ways to row.
True. Why I use balance in her case is because I also wanted to use balance subcutaneously, because if you notice, this line is skin deep, it's not deep. So I wanted to use one product which I can use to treat both sides, which is the subcutaneous injections in the nasolabial valve, as well as the and another point when you're injecting on the under eye area is that we have to be careful when we are injecting to choose the product which is not hydrophilic. If you're using a product which is hydrophilic, it is actually going to cause more swelling and you're going to have a lot of problem. Plus, if you're injecting superficially, that is something that you have to be careful with, because hyaluronic acid is going to bring in a little bit of water, and you don't want to block the lymphatic drainage, and that would cause sometimes swelling which stays for months and months, and then you have to actually melt that product. So intense would be sometimes I even use volume, but a very tiny amount in the medial pad of fat. And if the medial pad of fat is inflated, it actually supports the soothe very nicely. So I have injected, and when I'm doing under eyes, I always believe in under-treating rather than over-treating. Because this way, you can always add more, but if you put too much and it causes complications, it's going to take the confidence away from your patient. This is volume. Okay. So I'm going to take a little bit of volume and I'm going to inject it. No, with the needle, please. 30 gauge. Yes. And I'm going to support the nasolabial pad of fat by injecting a little bit in this area. Okay. Let's sit you up and see the difference between the two sides. So it's very moderately done. I have not put too much, but I'm also counting on diluted radius to lift up in this direction once I inject under the skin. So I'm not going to inject to as much as correction as I want, I under correct. So I'm going to go in here, and I use a needle always, and I'm using at this point Voltaire volume, and I'm going to inject in the periphery fossa around point.
So it's what I like to call a jackpot point.
Yes.
Because there is no point in the face where you can inject less and achieve more and have a higher patient satisfaction, because they still always focus on the nasolabial fold. But however, you know there is a facial artery in that region running around, so therefore it's also a high risk. So therefore the jackpot.
Exactly. Artery is usually between the skin and the muscles, and if you are on the bone, usually you are safe, but there are always an anatomical variation, so you have to be keeping in mind. This is a highly danger point. Now we will start with the diluted radius, and what we will do is we will compensate for the volume loss between the two sides. So what we have done so far is correction. After this we can do beautification by doing her chin a little bit if we have time. With the cannula, please. Yeah, this cannula. This radius is diluted at 1:1 ratio. So we have 1.5 cc of radius and 1 cc of saline and 0.5 cc of, so I'm just going to go subcutaneously. I'm going to come in from the other side. Please hold this one for me. Turn your face this way, please. So I'm subcutaneous, and I'm going to inject very small micro doses.
You're doing like circular fanning.
Circular fanning, exactly.
To provide maybe over a time, over the next 2-3 months,
Yes.
lateral lift by the new built collagen.
Exactly. And because this is the side that she actually sleeps on, I want to make sure that she makes a little bit more collagen in this area. And I don't want to add HA because I don't want to actually volumize her face. The Radius is a perfect product for skin stimulation and for boosting collagen and giving youthful results without adding too much volume.
And certainly you can combine it with cell therapy, especially in that region
Exactly.
where you are now.
And you're just below the skin, right?
Just under the skin, exactly.
And you use only one entry point to treat the entire cheek.
Exactly, I have used because I don't believe in creating too many holes in the face. And this point actually helps because if you're using a 50 millimeter cannula, you have access all the way to the jawline also. I will put a little bit in the jawline also.
Or for those who have a bigger faces, you can take 22G 7 centimeter long pen.
Here we go again with the
22.
7 centimeter. Are you being sponsored by TSK?
No, not a single penny, I swear, really. No, actually they should pay me something, how much
They
I
should.
want. Yeah.
All right.
However, it's
So I
not
have
about
injected-
marketing, it's about safety.
I have injected around 1 cc total and I have covered her whole cheek and her nasolabial folds. Now we're going to go to her chin and add a little bit of volume to her chin.
You see actually very nicely how her actually mouth corner is going up on the side, though it has been more down
And
than
goes
the other
up.
one before. And she becomes more contoured. I mean, you can't add a volume too much into her face
Yeah,
because it would be...
She already has a very
Sure.
circular face, yeah, and you don't want to do that. So I'm going to just put a little bit of Lido with epinephrine. Looking at her chin, she needs a little bit of anterior projection and maybe a tiny bit of elongation to make her face look less circular, yeah. So this would be considered under beautification. There. All right.
Would you combine, because she has like a little bit like a public chin and already initially visible sulcus.
Yes.
Would you use some haute couture in combination?
I always,
Serum?
yeah, usually actually the results are better if you use a neurotoxin before, and when they come back 2 weeks later for the revisit, if you inject
Just be aware in certain countries this might be off-label indication for haute couture respectively xeomine.
Some countries, absolutely.
In Russia, not.
No, in Russia it's on label. The whole face
In
is on
Mexico, is the whole face on label as
label.
well.
Colombia, I think.
I think there's another one in Latin America, but I'm not sure which one. So what are you using now?
I'm using volume now, and I'm going to inject around 0.05, almost anteriorly, to give her a little bit of anterior projection.
0.05?
0.005, you know, like it was, I have injected, yeah, just 0.05.
Okay.
And now I'm going to go here and inject around around 0.02. Yeah. But see, what has happened is now the center is looking a little bit more prominent and the sides are not that balanced. So we have to put a little bit on the sides to balance it out. So 0.25 here and
That looks great.
0.025 here also. And voila, we're done. How are we on time?
Yeah, well, you are perfectly on time. Maybe you can show us the final result.
Okay, so we'll let you sit up. So what we have done is basically we have augmented her medial soothe and lateral soothe a little bit and the deep medial pad of fat. We have augmented her piriform fossa to balance the nasolabial pads of fat, and then we have used the diluted Radius 1:1 ratio, almost the whole face to boost collagen in the next 3 to 4 months. And as beautification, we have added a little bit of a chin so her face gets a little bit more dimension rather than looking very circular.
Can you ask her to look straight into the camera?
Yes, please.
To the camera, straight.
Turn the head a little bit to the
Turn
right.
to the right. Yes, straight to the camera. Yes,
Yep.
yes. Now we can
That's
definitely see an improvement in light reflection, restedness, and I love that little pointiness of the chin.
Yes. And
Thank you so much, Dr. Shazia.
thank you very much.
Thank you, great job.
Great job. And now we are going to dive straight into your next presentation together with the one and only professor. After you? Oh, sorry. It's a surprise. It's a surprise. It comes later.
Yeah.
So how about voting
Afterward.
after your talk? So you're going to talk about how you treat heavy faces.
Yeah,
right?
it's actually a good transition from that young patient and live demonstration because that was one of the typical examples of young heavy faces, I would say.
Exactly.
So it's a perfect transition to my lecture. How do I do heavy faces? And actually, I said to Alexei, Alexei, why do I have to speak about heavy faces? I mean, here in the Middle East and maybe in Russia, you have much more of the heavy faces than we have in Europe. And then he said, yeah, but you have so many pictures. So I try to include really patients from different ethnical areas, and please don't make patients pictures. So I will be very happy. Can I have that one? Because I will start with first introduction on the anatomy of aging of heavy faces. Okay. Heavy face. Can we switch back? Now everything is blue. I think one of the biggest issues with the heavy face, never add too much volume. And rather try to slim these faces and to shape them. So now I have a question. Maybe we have that. No, it's later in that, before I ask that. We have the slides. Who can define the heavy face? What do you call heavy face? Oh yeah, here we are. No, this is Jana. I mean, I'm Tatjana. Shorten it would be a Jana, but with J and not with Y. So who can define a heavy face? I will, in my lecture, try to guide you a little bit to that. What can mean heavy face?
I think it's all about.
We have that, Yanni, I think.
This
so,
is it.
yeah. So heavy face. Let's look first on the non-heavy face. What is the ideal mandible neckline? So when we look here, we see this beautiful definition, distinct mandibular border. You see the subhyoid depression and the nose lip chin plane being about 3 millimeter chin retracted. But what is very important is for this area, when we speak also about the heavy faces, because usually they are missing the ideal mandible neckline, is the cervicomental angle. It should be 105 to 120, and in some patients with heavy faces, you can't even say where is the cervicomandibular angle. So, but what means heavy face, as I said? Actually, I went to the literature, and there is no definition, and there is no single big studies specifically on a heavy face. So I started thinking, okay, what means heavy face? Is that simply full, young? Is it young face, but saggy and ptotic due to the bad genetic predisposition? Or is it heavy, saggy face due to the aging? Definitely what we can say, and this is a German chancellor for the last 12 years, so we observed her aging very exactly, that if you have a heavy face, it shows accelerated aging, not regarding the wrinkles, but regarding the impact of the gravity. That means the sagging and the ptosis are having a higher impact. So let's look at the anatomy of aging or heavy faces. Multi-layered again. So what happens is
they have usually a heavier, thicker skin. That excessive black skin here in the lower face. However, the biggest impact on the lower face has the layer 2, the subcutaneous superficial fat compartments, especially the superficial nasolabial fat compartment, the submental superficial fat compartments, and the jaw fat compartments. Either genetically or alimentary, a high BMI, they are hypertrophic or enlarged, and also the submental, the facials and the submental. These play an important role. And I have shown you this slide before that at least 2 of those fat compartments, that is the superficial nasolabial fat compartment, the jaw fat compartment, show inferior migration with aging. And the superficial middle cheek fat compartments also show increased migration with increased BMI. So this is the alimentary heavy face. And on this, they're anyway always being moved down. However, what is heavier will also be under the higher impact of the gravity, because that's simpler things. So what we see also in the heavier faces, especially the aged heavier faces, is the more interrupted contour, and it's more prone to sagging, but interrupted contour because you simply have more accumulation of the superficial fat in front of the real ligaments. And also, we see in these, especially with the aging patient, the layer 3, that is below the superficial fats, like you see here, the subcutaneous fat, the platysma and everything else. We see the laxity of the SMAS and the platysma and the loss of the retaining support that is increased that. And also during the aging, doesn't matter if it's a heavy face or not, or less heavy face, we see the changes in the mandibular bone that also contributes to the lower definition of the mandible cervical angle. So, heavy double chin faces. I think we have to make 2 differentiations in order to choose the proper treatment option. Do I have palpable double chin? So is it consisting of fat? Then maybe even a weight loss might help to reduce the skin. You can use lipolytics, liposuctions, cryolipolysis, radiofrequency, so heat or cold, whatever. Be careful, sometimes after fat is gone, you will still have the skin laxity, so don't promise always the patient that everything will be perfect. Or do we have saggy, empty double chin? These are not yet published terms. I just developed them last week when I was doing this presentation. They're usually sign of aging, of the laxity, and these are best actually target for all therapy, for diluted radius, and of course demand a full facial assessment. So if I have saggy ptotic and or legs heavy face, my main purpose for the treatment is to lift and tighten. So as soon as I said lift and tightening, in your mind should make a click. Oh, this is a radius and or all therapy. 2 things is always better than just 1. So, I show you now a few clinical cases from my practice. This is a patient, you see age 68, BMI 29. What is the diagnosis? The diagnosis is the bone resorption, especially of the mandibular bone, lateral volume loss here, inferior medial migration of the medial superficial fat compartments, jaw, nasolabial fat, and she rather has a thick, not thick, but thick scar skin. So, what do I want to do is to promote more lifting by adding the lateral volume, but without making a face too big. So, what I'm going to choose is the Radius Plus, because it has the highest G prime and the highest viscosity. It is able to provide lift by adding lateral volume and to lift the lower fat of the face and to reconstruct the mandibular angle by imitating the bone. And you see the patient here, you see my injection points. So one is laterally from the jaw fat to injecting into the middle cheek fat pad, and are all injected hypodermally. And I also use the posterior temporal lift. Of course, I have done a little bit here into her cheekbone in order to give her another vector. So we have actually this very long vector here, positive from the zygomatic area, positive from the posterior temporal lift, and in the middle, respectively, lateral cheek fat pad. So what you see very nicely now, by adding a lateral volume and replacing the volume, we have much, much better definition of the cheekbone, of the mandibular angle. We have lifted these ptotic cheeks, and we have diminished the appearance of the nasolabial folds. And you see it even better, the definition from the lateral fusion. And also we have stretched the skin in the submental area. If I'm a patient like this, another diagnosis, this is an Asian patient, and you see Asians at the age of 46, they also age. Normal BMI, the diagnosis is the laxity of the skin and of course of the retaining ligaments and the SMAS. She has rather slight ptosis, no really hypertrophy of the superficial fat compartments in the lower face, what I call empty double chin, so you have to palpate, you can't judge it on a picture, and no significant volume loss. The target tissues and target layers for my treatment is the layer 1, the collagen in the layer 2 in order to lift the superficial fat compartments, the muscular nerve protective system, and especially in the lower face. So guess twice what I'm going to choose? The only treatment that offers the multi-layer treatment in one single treatment, treating layer 1, layer 2, layer 3, and even a little bit down to the 4 by treating the retaining ligaments, the ALF therapy, because in all of these layers we have a collagen. And what is also so great, seeing is believing. And I gave even my face to APEC to really promote the visualization of our therapy, because every patient needs individualized, customized treatment plan for the SMAS. By publication from Gabi and also Sebastian, we know that the SMAS might be in a different depth. It's not always 4.5, but I can't say it if I don't see it. Only what I see, I believe, and therefore a therapy, and customize the number of lines. You have to wait sometimes 6 months past, and there is no lipolytic injection because this was not fat, not the palpable double chin, but the saggy, empty chin based on the laxity. And we have improved the contour by using 578 lines. I always tell my patients our therapy will take about 4 months to really start seeing good results. Don't come earlier if you don't need anything else. And it will be prolonged over the next 1 year. And you see also better definition of the cervicomandibular angle on this patient. I show you this patient, young patient, 28, heavy face, no to mild skin laxity, mild ptosis of the skin and the superficial fat, mild submental laxity, and masseter hypertrophy. Remember Yanni's patient, she has a wide lower face because of the masseter. So my treatment approaches would be to slim the face, to get it to the more V shape, oval shape, to lift these ptotic things, to tighten and smoothen the transitions lines because I don't want to have interrupted contour. Okay, we started because it's sometimes a question of the budget. Not everybody can afford immediately for therapy, especially at the age of 28, with the lateral lift, using 1 radius plus. And what you see, we could actually lift and contour a little bit more the cheeks, but however, I didn't get a significant slimming of the face because of the masseter hypertrophy. So, what then I have done, in order to promote more lifting and tightening, and also to slim the face, is to combine our therapy, because this will treat also my submental area and not only the lower face area, and some thiamine off-label for the masseter hypertrophy. And you see the patient here after a couple of months of the treatment. So we're getting much, much closer to the V shape of the face. And what you do then, you just balance the entire thing a little bit. Smoothen the perioral area. Add the volume where you need it by doing some lip contouring and shaping for the lips. If you have made the rest of the face perfectly, then you can add actually a volume into these lips. Otherwise, they're going to be big. And you see the patients, when we have started in October 16 till April 19, so this is 2.5 years later, she is a beautiful young woman. We just make her a little bit more pretty by slimming her face, lifting the brow and opening the eyes, and lifting the ptotic fat compartments. So if you have a patient like this, She is, I think, 50 or something like that. Moderate skin laxity. Ptosis of the medial superficial fat compartments in the lower face. Lateral volume loss. She has much more laxity than the other patients. So what would be my preferred choice? It's the L therapy. Because she has accumulation. And look, this is 4 months post-L therapy. It seems like I would have added some volume here, but I didn't. There is no filler in this patient. This is the old lower fat compartments that are lifted up to the mid-face. So give and lift and give the retaining support. Then, again, visualization, of course, and you see it, it's not always 4.5, not even in a heavy faces. And now you can go with radius, in this case, of course, to support the tightening effect, but specifically radius plus with the high G prime, in order to provide her more shaping. You see here, we did a little bit of chin, a little bit of the cheekbones, and the mandibular angle, because we want to have a not only straight, but also defined jawline. And the Texas name comes from the very sharp, linear borders of the Texas state, actually. Not that it's too much. And you see the patient here before and after our therapy, 3 milliliter radius and 1 ml of bilateral volume. And this is a patient really also from the Arabic world. So if you have a patient like this is heavy face due to the aging. Don't try to lift this with fillers. Because whatever you inject in the mid-face, because of the loss of the retaining support, everything will drop down and make it even worse. So for me, diluted radius and our therapy, or one or another, is a must. And in this case, we started with our therapy. This is 5 months later, patient age 51. And you see, actually, it seems like I would have injected something, but it's a patient-owned tissue. And then after you have stabilized that, you continue with a little bit of AJ in the mid-face, bilateral volume, a little bit of radius for the contouring. And this is a patient 20 months past the treatment. So there is a bigger investment at the beginning, but you don't have to always spend the same amount. And the patients will look always better and better and better. And they will come back and say, I want something else as well, because you see this is 29 months. However, if you have a palpable double chin with excessive submental fat, add some fat reduction method and also to improve the laxity. Thank you very much. Excellent.
Tatiana, you won the prize for perfect timing. Because as you said, thank you, the timer went to 0. Amazing, this woman. So now we can introduce the voting. Okay.
You see why every man needs a woman next to his side, just to take care that everything is going properly.
So let's see the questions.
Yep. Okay. How many heavy face patients do you have in your practice on average? I don't think I have to read it. Is it 1/3, 50%, more than 50? Don't see any of these patients, or it's difficult to say, whatever that means.
Voting.
So, 15 seconds.
And blank screen. Just, what's your favorite? Okay, here we
Okay,
go.
it's running already, so it's just run the
5, 4, 3. Okay.
So, what do you think? Don't look, what do you think?
I think number 1.
1/3. Hey!
I saw that. I saw it. So 1/3 of my patients have this type of face. That's quite a lot, don't you think?
But if you define a heavy face like I have done, different types of the heavy faces,
Yeah.
I think that corresponds even to my practice, because they can be very young, a middle-aged, and a very old patient. It's not just the full faces.
Exactly, not just the full woman.
And don't forget the man, who develop also sometimes heavy face.
And even number 3 is more than 50%, and also 50% and more than 50. So this is quite a significant.
It's a quarter.
It's quite a significant chunk of the patient population with a heavy face. All right. So do we have another question?
I think we have another one as
I
well.
think we may have even 3, right?
Yep.
So for such patient, how difficult is it to create an optimal treatment plan to reach a high satisfaction level? So it's easy. 2, it needs detailed and thorough planning. It is untypical. 3, no problem, I sent it to a surgeon. Or 4, it's difficult to say. So how difficult is it?
Let's go. Or I send them to the diet specialist. Exactly.
Dietitian.
And sometimes that's the best option.
The
That's the first
dietitian is
option.
5. So,
What? I thought about 3/4 of the patients have heavy faces.
It's not
Why is that an
untypical.
atypical patient?
so it's somehow people are like maybe punching in their favorite number.
Yeah, maybe.
Instead of
You
answering
stick
the
a middle
question.
somewhere. Because it's always 2 and 3 if you look carefully at our answers.
But I think maybe the patient is not untypical, but you do need very good planning.
Exactly.
So I understand why they chose 2, even though it may not be
Yeah,
an
right.
untypical patient, but you really have to be precise into how to plan your procedure because you want to create a little bit of shadow here and there. You know, you want to
And it's
slim
not
the face.
possible to do it with one single treatment. You have
Exactly.
to combine and you have to explain to the patient why.
Yeah. And then the third question.
What's the most frequent combination used by you in the treatment of heavy faces? And looking for the questions, I already see one is missing. Toxin and fillers, toxin fillers plus injectable lipolytics, toxin fillers plus lasers, toxin fillers plus HIFU, and toxin fillers plus threads.
All right. The most frequent combination for heavy faces.
My answer would be probably in most of the cases all of that.
Well, and by high food, they probably mean microfocus ultrasound with
I hope-
visualization.
Oh, but look,
Oh,
toxin fillers and threads
great.
is the most frequent, and then toxin fillers and HIFU, it's, oh my gosh, I'm getting old. 36 to 30%. No. Let's see, how does it look like? How do I look like?
Very intelligent.
But it's so strong, thank you. So, I think, yeah, I know the threads are, do you do threads?
Video threads, yes.
Okay, do you think that video threads really lift?
Well, that's a debate. You do see some lifting, but actually, yeah, I mean, lifting a heavy face is quite a good idea, actually, with as least volume as possible. So, yeah, you could definitely use threads, different types of threads, or you could use, let's say, radius plus to target the retaining ligament, so you have a minimum amount of volume with a maximum lifting capacity to just focusing on these retaining ligaments.
Okay, I know that some people even combine toxin fillers, threads, and therapy, and that's also possible and is safe, as we know from the data that Gabriela has published.
Yeah, and I would say that the threads also give volume. So in that respect, I think the best combination for a heavy face would actually be number 4,
Yeah.
using of therapy and injectables for the.
Yeah, and where it's necessary, also injectable lipolytics, because if you have so much of submental fat that you can't reach this mass, then use the visualization, because then you see that you can't reach this mass. So how can you expect the lifting if you don't see where is this mass, and if you don't know if you can reach this mass and apply the energy precisely?
Yeah,
And
with liposuction.
okay, or like this, and that's exactly, now you can finally answer the topic of our next talk.
Finally, it is our great, great pleasure to introduce the one and only, my dear Professor Jana Judzkowskaja. Let's welcome her to the stage, guys.
First of all, I won't say you that I'm from Moscow. My name is Yana. My surname is very difficult for you, Yutskovskaya. This is more difficult than Baricic, I think. I'm from Moscow. And I would say you that you live in paradise. Because in my country now is +4. And after 1 month, we have maybe -14. And in January, all my country come to you. Because you live in paradise, once again. Here is amazing. And now I want to speak about heavy face. Why? Because Russia is a cold country. And fat for us, this is a leaf first of all. And 46% of the patients in Russia have a heavy face. We have a very beautiful woman, you see? Because I said that fat, this is for women. We must have a fat, but we must have a heavy face. I speak with you about my patient. I introduce you 2 cases with my patient, and I introduce you our research with heavy face and with methods working with heavy face. First case, I want to say that heavy face, this is not aging all time. In some situation, this is morphotype of the patient. This patient only 36 years old. She is very young. But she say me that this is big problem for her, jawline and fat of submandibular zone. She work in my clinic and I may saw and see her every day. What I prefer in this situation? First of all, you may see that I work with liposuction. Why? Because in my clinic I have a plastic surgery and I work with my plastic surgery together with all patients. Liposuction, this is very quickly, this is small rehabilitation, and this is very good result for a long time. Liposuction is the first, after therapy. And I will say you that therapy and liposuction together in one session, this is not dangerous. This is a very good result with short rehabilitation. We do it more than 3 years in our clinic. In one session, liposuction and ultrasonic procedure. You may see the graphic of this patient. And next, after 1 month, but in some situation, when I understand that my patient don't have a time, I do this in one session, radius. But here, for this patient, we did this after 1 month. I diluted radius more than 5 years. You know all our research with diluted radius. In this patient, I work with 1.5 cc, diluted radius 1:1, and we have a good result. You may see the result before and after, 45 angle and 19 angle. This is before and after with this protocol, with this patient. Next one. I think that this is a brilliant slide. Casabona, thank you very much for this. Because when I see this first time, I understand why lifting and volume may live together. Because we have a sagittal things of this zone of 3 of the face. When we speak about lifting for volume, this is very interesting. You may see my patient cases, 2 patients, different age, 43 years old and 60 years old. I take radius 3.0, diluted 1:1, and work in this zone. This very interesting zone for us because we may speak about lifting after the volume. My patient write me. This is what she write me after procedure, after 1 week. She won't be more older after me, you see. What she want, I don't understand. Maybe younger or older. But this is a very great result, I think. And in this, not important how much aging of the patient. Once again, here is a patient 43 and here is a patient 60. Next, my recommended for you, protocol. If we're speaking about grade of Merz scale 1 or 2, I prefer therapy such as mono procedure. If we saw grade in 2 or 3, I prefer ulcerapy and radius. And I want to say you once again, if you don't have a time, or if your patient wants very quickly, you may do this in one session. We don't have any problems here. Ulcerapy and radius together in one session. And grade 3 or 4, in this situation we must do liposuction. Liposuction plus ulcerapy and plus radius. If you want to do this in different session, you may do it after 1 month. Liposuction, months, ultrasonic, months, radius. Ulcerapy here, you may do together with liposuction in one session. And once again, our research, we like everything doing after research in our practice because we have a very interesting law in our country. We must say for our patient that this is not only very good result, this is very safety first of all. That's why we did research. You may see this, the 21 volunteers, 7 patients with liposuction, 7 patients liposuction with ulcerapy, and 7 patients liposuction, ulcerapy, and radius 1.5. This is 3 groups of the patient. Now we published this our research in very good journal, and I think that after 2-3 months you may read this in journal. And what is the result? First of all, this is first group with only liposuction. Next group, this is liposuction and ulcerapy. And third group, liposuction, ulcerapy, and radius in one session. And the conclusion. Group of the 1. Result is good. But we have a problem with the laxity of the skin after liposuction. Not all patients say that this is a great result. Group of 2, liposuction is very good result. Ulcerapy, we don't have very big laxity, but not all patients say that this is great result. And 3 group, this is liposuction, ulcerapy, and radius, everybody is happy. That's why I may say you this combine of this procedure is the future of our product. We must combine ulcerapy and radius because we're speaking about lifting of ligament and lifting of skin. Thank you very much. And when Tatiana come, I will say you that I want to invite you to Moscow, to Russia, because our country is very lucky. We like our guests very much. If you have a time, please come into Moscow.
I just can't agree on that.
I know, because you're coming to us, and we very like you.
Yeah, and the summer is not that cold. It's actually beautiful.
In the summer it's beautiful and not so cold. Yes, I agree.
Exactly, I was going to say maybe now is not the perfect time. However, I was in Moscow, I think 2 years ago in January.
This is very cold, you see,
beautiful.
and very snow.
Beautiful, I love it.
Beautiful because you live in cold country.
And I spent 2 days in your clinic, and it was a very memorable.
My clinic is very beautiful, I know.
Yes.
Thank you very much.
Thank you very much,
Thank you.
Diana. Thank you.
Diana.
So, and I think we will take these minutes that Diana gave us. And it was a beautiful summary, actually, on heavy faces. As you have seen, you have to make a diagnosis and then choose the proper combination. And if you want to have a lifting and tightening, as Diana said, and actually I'm here as well, and I just can agree, and you probably as well.
Absolutely.
The more you can do to provide lifting, the better it is. And the smaller the amount that you have to lift, the better the effect, because you're working against the gravity.
So do you think the gentlemen in the injection room are ready to start?
I hope they don't need a makeup, they don't need
They already look
to
good.
change their clothes.
But they do need a patient in the chair. So
Yeah.
let's see if we can get a connection with the injection room.
Thorsten?
Yes,
Frederick?
there's Frederick Byrne. He's
Maybe
here.
we can first introduce him properly.
Yes.
Because Thorsten has been on stage. So do we have, we would like to, okay, then I do it, doesn't need any video. I would like to introduce one of the best plastic surgeons in Scandinavia, in Sweden, plastic surgeon Dr. Frederick Berg.
Thank you very much for that presentation. I'm happy to be here, and this is a session together with Dr. Walker. You can hear me out there, right?
Yes.
Yeah.
Perfect. So what we are attending to is the lower third of the face, and basically we are doing two different kind of procedures with two different purposes. It's been attended to previously during the day. Basically, we have three different indications for any procedure: rejuvenation or restoration, enhancements or remodeling. And I'm doing the rejuvenation, as later Dr. Walker will show us some remodeling and enhancement of the same. So with me, I have Petra. Petra is 53 years old, basically a filler virgin. You haven't done... Oh, I changed. So when I tend to different areas, I like to work from above, because volume in this area will change even the lower area. And it's not that possible. Thank you. And this is basically the same technique as we saw before. Looking at anatomy, we have the malar fat pad. By lifting and pinching it, we can see the lateral border. So entry point, always lateral from that area. Underneath that fat pad, we have the pre-zygomatical space. And adding volume, in the pre-zygomatical space will not alter or change the morphology of our patient. So basically, depending on the patient and who it is it an Asian, we have the pre-zygomatical space more anterior. Then it showed us how we feel that resistance, and once we enter, we reach the pre-zygomatical space. We have a natural stub, the buccal maxillary ligament, and then we have the nasal fat pad. This is just some normal radius, volumized, time B. We're not changing our patient. Adding a little bit of volume and using about 1 cc for the...
You keep on moving the cannula.
Yeah, so it's about creating and giving the volume where I want it. This is a contained space, so it's not a linear technique, it's not a depot technique, it's more about volumizing where I want it. By doing that, we have the malar fat pad, and I don't know if it's visible, if we can have some shadow effect, but you can see when I lift that midface, the radii stay fixated. If we do superficial injections, the volume will move with the spine. By doing this, we assure ourselves that we will have a natural result, not only in a relaxed position, but even when the patient smiles. Basically the same thing as if you want to lift something up, we have to come behind it. You don't put subdermal breast implants, you put it behind the breast gland. Let's move out over here. So,
Can we have a look at the difference between left
Sure.
and right side? Very nice. Very clear.
So now we used 1 cc of radius for this area, non-diluted. And the next step will be to attend to the lower third. And we have here the DAO. And remember that all lines and wrinkles in a face, they have an origin. Most often the lines in this area are sleeping lines. So we can always tell what style our patient is sleeping. We're going to add a little bit volume in that tracheal sulcus to stabilize it all the way up to the chin. And I then will attend to lower back. So, Petra, if in there. If you can sit up and look down at a really short person, as we talked about before. It'll be too much, and we turn. You can
That's a
see-
good hint. We have to remind us, look at the very short person.
Yeah. Okay, please come. The 25. This one. So, I want to avoid that area with the inferior jaw fat pad. I want to avoid injecting into the masseter. I will have two different entry points. The 25-38.
So will you be injecting superficially or deep in this area?
Deep subcutaneous, and I'm not going down to the bone here. The superficial depends, it's a different definition. Of course, I will do real superficial here later with a washing technique. But now, my goal is to be deep subdermal.
So on top of this muscle.
Yeah. And using cannula is basically my three-dimensional GPS. So I can feel the resistance just as in the midface, so I will not go into this muscle or the muscle. Sorry for that.
You know, and for those people who use a needle on the bone there, if they think they are positioning 100% of the product of the bone, I must say that from that study that I presented today in the morning, actually, all of the injections at the mandibular angle ended up in a muscle. So it doesn't stay exactly on the bone.
That's what we found too.
Yeah.
And it was the same.
But I must say that sometimes just at the angle, I could use a sharp needle. So, but if I'm for a longer run, I prefer the cannula. I mean, we all know cannulas are safer, and with the cannula, we can feel the different layers. So that was number 2 out of 3 areas to attend to for Petra. Let's see if we sit you up and you can maybe see the difference step by step.
Absolutely.
So, as I came from here before, I'm going this direction now. I need to make another entry point since it wasn't perpendicular. Here in the pre-jaw sulcus, now I'm a little bit twisted here. We can use the cannula to show us anatomy. You have to excuse me a little bit, Petra. She's not numbed, so it's a little bit painful. This. Most of our pain we feel in 3 different layers. It's dermal, it's on the muscle, and it's on the period. But if I just lift it up here, you can see that I've catched the DAO, and if I reverse, you can still see a snap. So the cannula can show us where we are located. There. This is above, and this is underneath. Okay, now I'm deep on the bone. To straighten out that line. If I go up for the Marinette line, I would prefer to work with an HA. We're attending to that. This is a deep group. We're going to give Petra a radius dilute treatment in the full area. Stay down there. Okay, very good.
That looks really good.
So let's see if I can see in evaluation. So this is called the French technique. Thank you. Gentle, rejuvenate, break out that jawline, and then we're coming for the 4th step, which will be the washing technique.
Definitely more definition on that left side.
And looking down at someone, let's see. So now, not smile. Don't smile. And then we will more or less camouflage that inferior jaw factor. Okay. So now we move on. We have radius value. We valued it 1-to-1. And we've seen different techniques, but I love to use the value, really strengthen those dynamic laugh lines.
So is this a 1-to-1?
1-to-1. Just as shown by previous line injection, this is scraping down the knees of the dermis, retrograde injection. Take her here. Thank you. Always be careful not to contaminate your camera. Hey, Petra.
She is a perfect patient, huh?
Definitely.
Okay. Is she Eastern European? Where's she from?
No. Is German?
Netherlands.
What do you mean? That it's easier with the Eastern European patients?
Yanni believes that Eastern European women are more ready to suffer in order to become more beautiful.
In Japan.
I guess you've been to Korea as well. You never see a movement on a South Korean patient. Here you can see how I ended up too superficial. Well, sorry, too deep. So I need to be superficial.
So we're almost half-time.
Yeah, and I am basically done. I'm doing only left side, and then I do the other side off camera.
This is the area that always gets easily bruised. It doesn't matter if you use the cannula or
Definitely.
because of the
So,
muscle fibers.
And because you're in a hurry, because it's the last part of the...
and what you pointed out is interesting because the DAO has intradermal insertion. This is why it pulls it down. So while we do this with the cannula, it actually releases. Okay.
Yes.
I would add, I have only radius to work with in front of the camera, but I would add Velatero for this area in my practice. I will do it off camera. You can have some more if you want. So,
Great.
good face, left side down, right side, gonna do it off camera.
Very
Thank you.
elegant.
Thank you very much.
Amazing. Thank you
Thank
so
you
much,
very much.
Frederick.
Thank you.
Great.
Thank you.
Now we're gonna,
So we're gonna...
You guys are changing the chairs. Where's our iPad?
Where is our iPad? I think it was over here. Maybe there's some questions, actually.
You know, yeah, because I remember one question. Yanni, maybe you want to answer that. How do you avoid air when mixing a radius in order to get muted radius? I actually personally believe it doesn't make any difference and it doesn't matter. But do you face this problem?
Yeah, you know, if you mix radius with lidocaine and saline, then you basically have to put the luer lock connector on your syringe. And so what you have to do is just express a little bit of either lidocaine or radius inside the luer lock connector so you don't have air that you will put into your mix. Because otherwise the gel will become compressible. And that's not,
And it's more
not nice.
difficult to inject them because
We
it
have
pops
a
out.
question from the audience. So that was a question actually to Frederick. On the cheek, what level? Was it bone or what was it?
For the sleepy lines, that was subdermal.
On the cheek?
On the cheek, that
yes.
was below the smash.
That
You
was
mentioned that.
supraperiosteal. And then there was another layer on for the skin quality improvement.
Because if you want to add a volume here and you add it super smashed, what happens? That means you are also above the muscular layer. And every time when you smile, the zygomatic smile will push it up. And that's what I call a ping pong effect. A little bit, it's okay, and for skin tightening, it's okay, but not to really create a volume.
So there's another question for Frederick, actually. Maybe we can try and answer this one. Frederick, you mentioned sleep lines formed by folding of the skin. If such an entity does exist, why is it limited to the face, and does it occur on other body sides where the skin folds up during sleep as well?
As a woman, I must say that's not true. It appears on the décolletage when you sleep. And when you turn 40, you start to see them. And then you start to think, what can I do? And you start either with therapy or with uvulated radius. So
Thank you, Tatjana. That is totally correct. I mean, and even the bigger the implants you choose, the more prominent the sleeping lines become. So sleeping lines occur everywhere. And of course, looking at patient, for example, peroral lines, it's not smoker lines, that is sleeping lines. Look at a lot of famous actors, you can see which side they are sleeping in by just looking at the forehead. This is just sleeping.
Thank you,
great,
Frederick.
thank you.
So I already saw Torsten really prepared
Torsten, are you ready?
and ready for action. Am I right?
So in opposite now I have Christina here. She's my patient. I brought her from Germany, to be honest. She's one of my patients since several years now. And it happened by incident that she's on vacation here, and I grabbed her and said, when you're on vacation here in Abu Dhabi, in this beautiful country, would you like to be my model? And of course she agreed. Hopefully I can make her very happy for today. She's an ideal candidate for the so-called Texas face. What do I understand as a Texas face is that you widen the bigonal distance and sharpen, especially this area here above the masseter muscle, just to sharpen the face and to make it a little bit more masculine. Honestly, I think it's quite difficult in women. They have to like it. It's a kind of beauty approach. If you look at all these supermodels of the last years, they have these sharp-shaped bigonal distance lines here. But sometimes it masculinizes too much. So what Christina, she's 41 years old and she's ideal for this purposes. Can you zoom her a little bit? And you see that she's quite wide here in this area, and that she loses a kind of protection here on this mandibular contouring. So we make it a little bit, or try to make it a little bit more pronounced, a little bit more projected here, especially 1.5 or 2 centimeters from the earlobe anteriorwards on the jawline. She starts also losing some fat here. It's very, very discreet. She has some hyperpigmentation, so don't mix it up. But she starts losing also fat here. But she's not, for me, a candidate, maybe just a little bit to enhance her midface, and that's a different technique. We just focus here on her bigonal distance and on her mandibular edge and contouring. So the first thing I'm going to do, I let the patient clinch on her teeth. You can see my bicep clinch, and you see, relax. And you see or you feel and you palpate that masseter muscle is really coming upwards a little bit and pushing it outwards. So this is my first injection point. So I palpate masseter muscle, clinch once more. Here's the maximum, here exactly, relax. And I stick my needle now and put some bilateral volume under masseter muscle. What's the idea of it? I make a more kind of bread bit shape in her bigonal distance. The muscle covers it, so it's a very easy technique, and in this case I use a needle, which I rarely do, and I place the product on the bone. So now you can relax, lay down, and it's just a bolus and a single shot injection. So it's just 1 cc per side. Sometimes in males I put 1.5 cc's per side under the muscle. And the product of choice is bilateral volume in this case especially, because as Tatjana said already, you put the product actually into the muscle, or some of the product will be in the muscle, and that's not allowed to do so with the radius. Clinch once more, relax. It's a perpendicular injection downwards. I touch the bone, so you have to have a long needle. Just place gently, but slowly. Pillar. I touch the bone. 1 point here. Going out. And the second point. Is it okay? It's a little bit painful, I know. And sometimes the patients have problems opening the mouth. I told her in advance that this might happen. So eating a big meat might be a little bit of a problem. And I put 1 cc as a bolus on the bone. There's no risk of any vascular compromise. And that's it. Okay. And you should see a little difference. Can you see it? It's more defined already here, but it's still, you see she has a little hole here. Can you do more like this? Maybe like this. So you see, more defined here, but she's still missing something. So the second thing I'm going to do is fanning radius, a little bit diluted, subdermally. And there I need my introducer, and as Tatjana already mentioned, we're on the same track. I use TSK cannula for this purpose. Taking the skin into my hands, 45 degrees angle, thank you. Having my cannula, it's a very short one. I like it less flexible, more stiff, then I'm more precise in the area I'm injecting. I hate when the cannula bends. And now, there's some problems. Sometimes they bleed like hell, sometimes they never do. I'm in now. A little bit fibrotic in this area here, so she has to tolerate some pain. And if you have a very flexible cannula, you never know precisely where you are. And I'm injecting slowly, but constantly, some radius, subdermally. And you see, it's very visible here now. It's very visible. You see just that she develops a kind of sharp contour and sharp angle here. Can I get the introducer once more? Yeah. I just make a second insertion because my introducer directs me. Thank you. And then I'm taking, rotating a little bit. This and subdermal. Also, here's my jawline. I'm doing the subdermal injection along the jawline just to enhance the jawline a little bit. Also going downwards just to make a more sharp contour in her case. And you see, it's a little bit defined. And now I can massage it. The product I've been using is Radius. I just added a little bit of lidocaine in her case, but not completely hyper-diluted because my idea behind this, I want to create sharp lines, so I need to volumize, I need to fill in this case, but also I have to stimulate the collagen production. Can you sit up now? There should be a difference on the screen. Here, more defined, and I will add some more maybe, if she's not enough, but she will start swelling. This is the disadvantage of Radius. A little more, okay, just to enhance the bigonal distance a little bit more. That's what I understand is the so-called Texas phase. So you widen the bigonal distance, create a sharp line, and here I was too gentle. It's a little bit more. Is it okay? Very painful for you? Okay. Okie dokie. So, and here we are.
Micro? Oh yeah, okay. Thorsten, I think why you have been so gentle, it's because in Germany, of course, for now almost 2 years, we have the Radius Plus. And
Yes.
this is, of course, having a higher viscosity and a higher G prime, so we use that with a little amount of Radius Plus, we can achieve even better results.
That's-
More sharp definition. I call it the iron stick, actually. So if you want to put an iron stick
Yes.
into something,
It's-
you put a Radius Plus into it.
Yeah, I also
Just will not
thought,
spread at all.
I also thought of using Radius Plus, so undiluted one, but then I thought, okay, it's a workshop, it's on stage, and I didn't want to risk any irregularities, any swelling, so that's why I added a little bit of lidocaine and hyper-diluted it to a certain point, but it was not completely hyper-diluted, it was not a one-to-one hyper-dilution, it was just added a little bit of lidocaine just to soften it out.
Thorsten, do you sometimes, because you use for the definition of the mandibular body, the insertion point at the mandibular angle. I more frequently use the medial insertion point, especially in an older patient if I want to prolong the mandibular angle further back, because if I choose my insertion point at the mandibular angle, then I can't prolong the angle back.
You mean you go from here and push it backwards like this and get a kind of pulling here in the face? That's absolutely correct. I also do it sometimes if it's really necessary, but in her case, I like the result so far with the more definition. I do not want to, well, maybe you could do to make her too wide, too big on the mandibular edge because she's feminine and I want her to keep feminine.
Okay, so when we speak about the jawline and the Texas face, what do you think about her chin?
She needs definitely some volume here in the chin because she has a retrograde. Can you turn to the side like this? She needs some more anterior projection, a little bit projection outwards because she has a flat skin. So this would be absolutely a good indication. You're absolutely right on her just to make one long line, Steiner's line from the nose to the lip. Yeah, you're absolutely right.
Wouldn't you agree that treating the lower face in this patient, I mean, I would not let her leave my treatment chair without injecting filler into her chin.
Yes, but you know she doesn't want it maybe, so we have to discuss this. But we also have been discussing, can you contract now like this? She also has quite strong platysma bands. Sometimes so I really would also go for some zeomine injections.
That's great therapy.
Yeah, and maybe therapy. I do not offer it in my clinic, so but we have to do with what I can do. But I also would go for some zeomine for the platysma here as well. So there are many approaches which lead to Rome, as you said, but the topic was giving Texas face to Texas chin by normal distance, and that's what I covered.
First, can she look straight into the camera? Because now a little bit more turn her head to her right.
More like
Straight.
Yeah,
In the camera.
because then we see better this really rectangular definition, like I said, the border of the Texas state.
turn like this, and go.
No, straight to the camera. Let her look not on the screen, but in the lens.
Then look to the lens here.
Yes, like that, and straight.
Yeah. It's difficult because the camera is too high from the chair.
Ah, okay.
It's not in the same position.
Okay, but we see really the definition and the widening of the mandibular angle in that area. And the sharp.
And I was very gentle. You can always do more, but you know, my approach is to be less. Sometimes less is more.
Yeah,
Especially if
and she
you're
lives
safe.
in Germany, you know, this is what we also have to consider,
Yeah.
that these patients always want a little bit less than maybe somewhere else in the world.
Exactly.
And if she
Right.
needs more, she can always come to my clinic and we add a little bit more. But the technique still stays the same, you know.
Yeah, but it's not, can she smile again?
It's my lachen.
Look when she smiles, how the position of the corner of the mouth on her left side has changed in
That's
comparison to the right side. Actually, when she's resting, you don't see it so obvious. When she smiles, you see exactly how actually adding this volume at the jawline actually also improve the appearance of and the position of her mouth corners.
Yeah, it's kind
And
of
our
like the
occlusions.
horizontal vector of the lift, right?
Exactly.
Like this. So really, now
Great.
it's defined.
Okay. So
I'm going to the other side. Good.
I guess.
Yeah.
I finish.
Sorry?
I finish off stage because I think we're already in a hurry.
Clinch. Can you clinch? Can she clinch? There was a question from audience to clinch.
And Zähne
Ja.
zusammenbeißen.
Bite.
Bite.
Right.
Nochmal Zähne zusammenbeißen.
She has also very strong temporalis muscle. You see it pushing out when
Yeah.
she clenched feet.
Good.
Okay. So,
think-
Annie, do you have any questions?
We
Otherwise-
have one actually. We have a question by Osama. Does therapy affect fillers? Changing the position of the filler or destruct hyaluronic acid?
Okay, you know what? I would like Gabi to join us on stage because she has done a study and I don't have to comment this. I have, of course, the answer to that question.
Does she
But
have a microphone?
can you give her a hand microphone, please? But as we have her here, and she
Yes.
has done all of this work
She
with
should answer
therapy
this
and
question.
fillers and therapy and threads, I think we should give her an opportunity to answer that question.
Okay, so the answer is no. So I think it was the first study I published 7 years ago.
Yeah.
And I studied not only Othera, but non-fractionated laser CO2. So I did an inner thigh, one side with hyaluronic acid, the other side with radius. And I put immediately after injecting subcutaneously and intradermal injection of Radiesse and hyaluronic acid, I would put the technology right away on top, using the same density that we normally use, and biopsying 6 months after. So a month, 3 months, 6 months, and 9 months. So I would do the biopsies and evaluate according to collagen formation, elastin, and inflammatory process. Nothing happened with anything. But in the end, we could see that there was a significantly difference in collagen stimulation in the comparing with the control area with just the fillers. The one that was not the control area, all the technologies combined would stimulate more collagen in the area. No stimulation of granuloma, inflammatory process, or anything of any kind, neither with Radiesse nor hyaluronic acid. I cannot tell about duration because 9 months is too short follow-up, or too short to look at. I would have to wait 2 years.
Still pretty long enough.
Yeah, but 9 months, there's no difference. There was actually a difference in between how the filler, instead of looking like a big lake of filler, because I would put like a big bolus of 0.3 in each area, when you put the technology compared to the control, the biointegration, not Radiesse, but the hyaluronic acid is bigger when you put the technology on top, but not really different aesthetically, or when you look, I used to put a lump, so I could see the lump through the 9 months. I didn't see any difference clinically.
Thank you. Thank you very much. Should we do this last question?
Yep.
For Torsten, for the Texas angle enhancement, do you do the same technique in male and female? You came up very vertically in this female, which was maybe a little bit masculinizing. What about going more posteriorly towards the earlobe, which lengthens the jaw?
That's my question.
Was that your question? That was actually my question as
I
well.
was sleeping.
Actually, going more laterally is less widening the face, because that could be a bit masculinizing. But if you go more posteriorly, you can get that really great contouring and redefinition of the jawline without definitely accentuating the masseter muscle. Yeah, very, very good
Very
point.
good question. You know, but when you look at the Angelina Jolie, that has actually very nice defined and wide lower face. I think that in the lower face, she looks a little bit masculine, and I absolutely agree with that question. If you make it too wide, you make a female masculinized.
That's what I'm saying, but the thing, the goal was here, she was flattening on the left in front of the earlobe, so I had to widen the bigonal distance. And when you saw me injecting quickly, I was also, do they hear me? I was also going posteriorly a little bit, like doing a hockey stick augmentation. So I
Hockey
did it.
stick is a good word.
Yeah.
So,
Now?
how do you feel?
I feel good.
Yeah? You don't need a little bit of energy?
No,
You want to
I always have
continue?
enough energy.
You want to skip the coffee break?
I don't think that people would forgive me if
No,
I
I
said coffee
need
break.
a coffee, guys. I just want a little bit.
You are
of
just a
energy.
man, and that's okay.
Okay, guys.
Okay, we go to the coffee break.
And we will be back here at 5 p.m. See you very shortly. And
No, let's do 10 to 5.
that is in 10 minutes.
I'm German.
All right, 10 to 5.
You can say 10 to 5 minutes. I'm going to call you 10 to 5.
Eu, esse tá também.